I went to medical school to become a geriatrician. It was the only type of doctor I have ever wanted to be. My name is Kenneth Rockwood. I'm a geriatrician in the Department of Medicine at Dalhousie University and at Nova Scotia Health. I also am the Senior Medical Director of the newly formed Frailty and Elder Care Network. At Dalhousie, I'm a professor of geriatric medicine and neurology. I'm also privileged to hold the Dalhousie Medical Research Foundation Kathryn Weldon Professorship in Alzheimer Research. What I've enjoyed particularly about Halifax and being here, the work is very rich and quite fulfilling, but also from a professional scientific standpoint, I've been really fortunate and privileged to be sponsored in two ways. One is my time has been paid for, if you will, the scientific clinical research component of it, through the Dalhousie Medical Research Foundation's Kathryn Weldon Chair in Alzheimer Research. And the other component of it is I've been sponsored by the Fountain Family Innovation Fund at the QE2 Health Sciences Center. I grew up in a household full of books. I lived with my mom's parents, and my grandfather was an Anglican clergyman of some renown. He was a great intellectual. I also, in my family when I was growing up, was inspired very much by stories from relatives who'd done really cool things. We had one great-great-uncle who had built some important lighthouses around the coast of Newfoundland. And the idea that you would do something that had a lasting impact and that it was an evidently good thing and that it was kind of tough, all those things seem to make a lot of sense. And that manifests itself in varying ways in me. So for example, for a few years, I was a firefighter and I learned all sorts of cool things about how teamwork actually worked, about how decisions were made under constrained circumstances with incomplete data. And it was experiences like that that really all seemed to me to come together in geriatric medicine. So privileged in so many ways, and across my career I've worked with fantastic people. Got my start working with two geriatricians, one a man called John Brocklehurst, who in those days was the world's leading geriatrician, come up with the world's first textbook of geriatric medicine, and a man called Duncan Robertson. I was also extremely fortunate to work with a man called Paul Stoley. When I moved here to Halifax, I had great clinical colleagues, and in that team that we put together, there's still some people from those days who work with me now. Probably the person whom I owe the greatest debt intellectually is Arnold Mitninsky. Arnold was a mathematician. He died just in May of 2021. He and I spent a few years trying to figure out what frailty was. We started each with the idea that the other person was going to be helpful in some way, but mostly with mutual incomprehension as to what each other was talking about. So one thing that Arnold and I worked out early on was something called the Frailty Index. And the Frailty Index is a way to understand how fit or frail an individual is. Such that studying how the Frailty Index behaves in different illnesses or in different populations or in different samples gives us some insight into how to improve care or how to prevent frailty. And it also gives rise to this important idea that people aren't just frail or not frail. As the pandemic unfolded, a lot of the insights that we had developed as a consequence of that work, which went on for about 14 years prior to the pandemic, wound up being quite useful. When a formally complex system is about to fail, it often fails with its highest order functions first. So for humans, the things that we've evolved to do, stand upright, not fall down, pay attention, use our opposable thumbs, engage with other people, those are the things that tend to go awry when someone is really quite ill. And those things are common in older people who are acutely ill, and they wound up being very common with COVID. And that was a challenge because the expectation was you should know that you had COVID because you had a cold or you had a fever. And yet the early studies started to show that that wasn't the most common way that an older person showed that they had COVID. It was that they got confused, or they had decline in their function. And these were challenges. So we had a couple of tools that helped with that, but I think the most important one was a thing called the Clinical Frailty Scale. And it grades the degree of someone's overall health, their fitness and frailty, at the 2 weeks before they get ill. And we were able then to put into practice and think clearly about all the ways in which frailty would predispose someone to get COVID-19. So if they were exposed, how much of an exposure did they need before they developed the illness? If they got the illness, how did it express itself? Winning this award, I'm hopeful that it will be a big boost for the work we're trying to do. And there's two types of work. One work is the research, but also the work I'm doing now as the Senior Medical Director for the Frailty and Elder Care Network. There's a lot of things that we're keen to introduce here. There's things that we've seen work elsewhere in the world, and I want to get the chance to try them here. Whatever we can do to bring forward the message that frailty is a manageable condition, and it's something that we need to get used to being happy with as healthcare providers, and not looking at people resentfully, which we won't do if we're no longer frustrated by the apparent complicatedness of their illness. I'm hoping all these things will speak to better times ahead for research on frailty and for clinical care of frail older adults, particularly when they become acutely ill.